Hello everyone, I'm Hee-Kyung Ko. It's honored to present our study on cGAN-based synthetic city for MRI-guided transcranial focused ultrasound. Transcranial focused ultrasound, TFUS for short, is a promising technique that can treat brain by non-invasively transmitting acoustic energy. Thanks to its advancement, it has widely used for thermal ablation and also has gained momentum in BBB opening and neuromodulation technique. Single element transducer is a TFUS treatment configuration which is relatively cost efficient and less complex, but it needs mechanical steering due to absence of page correction mechanism. MRI-guided system is crucial in steering acoustic focus of single element transducer. Since SCAR can induce distortions in acoustic propagation due to large mismatch of acoustic properties, the guidance system requires acoustic simulation. It estimates acoustic field within SCAR and should be performed before the treatment. The simulation conventionally requires CT, not only MR. MR is to obtain individuals' brain anatomical structure and to define target region. Meanwhile, CT is to obtain skull structure and derive it to acoustic properties. However, CT scanning accompanies exposure ionizing radiation that may increase patient lifetime risk. It could be bigger burden to specific patients. Also, additional scanning requires increased cost and workflow such as registration. Thus, as an alternative to CT, the objective of our study is to generate synthetic CT, SCT for short, by deep learning method called 3D Conditioner Generative Adversarial Network. We like to call it 3D cGAN. Then the main goal is to examine the feasibility of SCT by acoustic simulation of our TFUS system. Let's see 3D cGAN first. For the model training, MR and CT were acquired on following parameters. 15 sets were used for training, 10 sets for the validation. To make pair data set, pre-processing procedures such as BS field correction, registration, and binary mass segmentation were applied. Those data were fed into 3D cGAN to learn MR to CT generation. The network consists of two models called generator and discriminator, which are trained together but adversarially. The main role of discriminator is to distinguish real CT, RCT simply, and SCT that generator presented. For that, discriminator was trained to predict the correct level, true for RCT, false for SCT. Meanwhile, generator is an encoder-decoder type model that aims to generate realistic CT from MR. The adversarial loss was used to enhance the misjudgment of discriminator by labeling SCT as true one. And the mean p-norm gradient difference loss minimizes differences of intensity and gradient, which help SCT to be more CT-alike and less blurry. This is a representative of SCT among 10 validation subjects. The difference with RCT and the 1D profiles of HU intensity indicates a considerable accordance. To compare skull structure of both CT in detail, skull density ratio, which were conventionally considered before sonication, was estimated. The result showed high correlation when the transducer was positioned aiming for 3 brain regions and didn't show significant difference between RCT and SCT. Moreover, the skull thickness of them also revealed high correlation with no significant differences. With such evidences, we could infer that SCT achieves similar skull structure to RCT. As a reminder, our main goal was to perform acoustic simulation to examine the feasibility of SCT. So RCD and SCD were implemented into our MR-guided TIFA system. Acoustic simulation of the system is based on single-element transducer and K-wave toolbox. The acoustic property of scores such as speed of sound, density, and attenuation were calculated with following expressions by HU intensities derived from both cities. Simulations on various entries and targets were performed for the validation. It's an example of normalized pressure distribution of acoustic field on both cities. The absolute difference in the acoustic simulation shown in the last column indicates that the simulation results were similar, especially in the brain. To see the results in detail, the peak pressure ratio were obtained where P indicates intracranial peak pressure. The box plot of peak pressure ratio shows overall error under 4%. And the dissimilarity coefficient, which is an index of volumetric similarity, were obtained by overlapping acoustic focus volumes from the RCD and SCD. The volumes were set as 90% maximum of intracranial acoustic focus. The box plot indicates that the overall similarity was about 0.85. And the distance of centroid of those acoustic focuses were under 1 millimeter overall. By those evaluation metrics, we could conjecture that 3D cGAN-based SCD can induce comparable acoustic field. As a conclusion, SCD achieves similar anatomical structures compared to real CT and shows agreement on simulated acoustic field. This evidence supports that the 3D cGAN-based SCD is promising as an alternative to CT for MRI-guided TIFAs, and the feasibility study should be continued to be pursued. In future, the applicability of various MR sequences on 3D cGAN should be defined. Furthermore, our study will be extended to examine the error rates of dermal rise when SCD is implemented, including feasibility study on multi-array transducer system. Thank you very much for your listening, and if you have any questions, please feel free to ask.